Hello everyone and welcome to our module on aortic dissection.
This is an image from a CT scan, a CT angiogram of a patient with an aortic dissection. And you should get used to recognizing aortic dissections by CT scan because this is the type of thing they like to show you on board exams, and it's actually fairly easy to recognize this condition even as a first or second year medical student. So if we look at this image on the screen here, all the white areas like the one I'm putting my pen through are where blood flows. Contrast material has been injected into the venous system and it's filling the body, and everywhere that blood goes is going to be bright white. This structure right here is the pulmonary artery, and anterior to that you have the aorta. That's right here where I'm marking with my pen. And if you look at this aorta, you can see that there's a line through it. That line is a flap of tissue called a dissection flap. So what's happened to this patient is blood has penetrated a tear in the intima layer of the aorta. This has allowed blood to get between the layers of the aortic wall. That's why it's called a dissection. This has created two lumens for blood flow. There's this one right here and also this one right here. One of these is called the true lumen. That's where blood is supposed to be flowing. The other is called the false lumen. Usually the smaller lumen is actually the true lumen, and the larger lumen is usually the false lumen. That's because the outer layers of the aorta are relatively stretchy, and once blood gets in there, it can really push these layers apart and create a wide lumen for blood flow. That's the false lumen.
So to understand an aortic dissection, you need to recall that there are three layers to the aorta. The intima is the layer right next to the blood that is flowing through the vessel. The media is the middle layer, and the outer layer is called the adventitia. In a dissection, there's a tear in the intima layer of the aorta. So if you look at this picture here, I've shown you the three layers, the adventitia, the media, and the intima. In an aortic dissection, there's a tear in the intima. It allows blood to get into the plane between the media and the intima. That blood is said to dissect those two layers and spread them apart, and that's why it's called an aortic dissection. Once blood enters the plane between the layers of the aorta, it can propagate. So for example, if we look at this drawing on the screen, imagine that there's a tear in the intima at this point right here. Blood then enters the plane between the intima and the media, and it can propagate. It can spread distally down towards the abdomen, and it can spread proximally back towards the heart. And when it does this, it can disrupt flow to blood vessels. So the reason aortic dissection is often brought up on the USMLE Step 1 exam is because it can be used to test your knowledge of the anatomy of the vessels that come off the aorta. And in a minute we'll talk about the different symptoms that can develop depending on which blood vessel coming off the aorta has its blood flow disrupted by the aortic dissection. From a clinical point of view, we divide dissections into two types. The first type is called a type A. This is an aortic dissection that involves the ascending aorta and/or the aortic arch. And type A's are usually treated surgically. The reason for this is that the mortality from a type A aortic dissection is very, very high if surgical intervention isn't performed. The surgery for an aortic dissection is to remove the damaged portion of the aorta and replace it with graft tissue. And as I said before, this is almost always done for type A dissections. Type B dissections, on the other hand, involve only the descending aorta, and these are often treated medically. The way you medically treat an aortic dissection is to control the hypertension, which is usually present. The hypertension stretches the aorta and drives blood into the dissection plane. You also control the symptoms. And if you treat type B dissections medically, they often stabilize and the patient does not require surgery. And the reason type Bs are treated medically is because the mortality from surgical intervention is very, very high, and the mortality from medical intervention is also high, but it's usually lower than the mortality if you go to the operating room. The symptoms of an aortic dissection are tearing chest pain that radiates to the back. In real life, there are a variety of vague symptoms that can develop, and diagnosing an aortic dissection can be very difficult. However, for step 1 of the boards, it's almost always going to have classic symptoms of tearing chest pain radiating to the back. So remember what I said before, dissections can propagate and cause many other symptoms by disrupting flow of the vessels that come off of the aorta. So first let's talk about what happens if a dissection propagates to the root of the aorta. Remember that the heart is sitting at the root of the aorta, so is the aortic valve. It's this portion I'm circling with my pen. So if that portion of the aorta dilates and stretches from a dissection, that can cause aortic regurgitation. Those leaflets of the aortic valve will not be able to come together normally, and blood will leak backward through the aortic valve. In addition, the dissection can enter the pericardial space and cause a pericardial effusion or tamponade. And then finally, the coronary arteries come off of the aorta. The right coronary artery is particularly susceptible to obstruction. It comes off at a relatively high point here. And when the right coronary artery has its blood flow disrupted, that can lead to myocardial ischemia from a dissection. If the dissection propagates to the aortic arch, it can cause a stroke by disrupting blood flow into the carotids. It can interrupt the sympathetic nervous system chain and cause a Horner syndrome. And then finally, it can cause vocal cord paralysis by disrupting the recurrent laryngeal nerve. By way of review, the recurrent laryngeal nerve is a branch of the vagus nerve that supplies the larynx and the voice box. It wraps around the aorta as I'm showing with my pen, so if the aorta becomes enlarged from a dissection, this can compress the recurrent laryngeal nerve, and that can lead to symptoms of hoarseness of the voice. So compression can occur in aortic dissection as we're discussing now. Another situation where it can occur is if there's massive left atrial enlargement. The left atrium sits right here below the aorta. If it becomes massively dilated, which can happen in mitral stenosis, that can also cause compression of the recurrent laryngeal nerve. Two other classic findings seen in aortic dissection include a blood pressure differential between the arms. For example, the systolic blood pressure in the left arm could be 180 and in the right arm it could be 120. That difference occurs because blood flow is obstructed to one arm by the aortic dissection. A second classic finding is a widened mediastinum seen on chest x-ray. This is an example of one on the screen. The mediastinum in this patient's chest x-ray is very large, and that's because of an aortic dissection. In actual clinical practice, the diagnosis of aortic dissection can be difficult to make, and unfortunately, sometimes this disorder is not diagnosed and the patient dies as a result. An aortic dissection is often suggested by a history of chest pain. It can be suggested by a blood pressure difference between the arms or by findings on the chest x-ray. However, the definitive diagnosis is usually made with a CAT scan like we saw at the beginning of this module. Sometimes it's also made by an MRI, and it can be made by transesophageal echocardiography. And then finally, you should be aware that there are data that the D-dimer level is elevated in patients who have an aortic dissection. When blood gets into that dissection plane, many clots form, and as a result, D-dimer levels can be elevated in the plasma. This is a sensitive but not very specific test. Some institutions use this because a normal value makes an aortic dissection unlikely. Now we're going to talk about the risk factors for aortic dissection, and in order to do that, I want to review a few general principles about the aorta that will hopefully help you understand the risk factors and also to remember them. So first of all, you should know that the medial layer of the aorta, the middle layer between the intima and the adventitia, is what gives the aorta its tensile strength and elasticity. And there are two very important proteins that are responsible for the tensile strength and elasticity, and those are collagen and elastin. If there is a weakness of the medial layer for any reason, then the aorta generally becomes weak, and it's vulnerable to dissections and also aneurysms, which we'll talk about in a minute. And in fact, a common feature of all aortic aneurysms, which we'll talk about later in this module, is medial layer damage or destruction. A second general principle is that of the vasa vasorum. This is a network of small vessels that's found primarily in the outer layer, the adventitial layer, and it supplies blood to the medial layer in thick vessels like the aorta. So if a patient has thickening of the vasa vasorum, as you can get in hypertension, this can lead to decreased blood supply via the vasa vasorum, and that can lead to weakening of the medial layer, which, as we talked about before, is very important for maintaining the strength and elasticity of the aorta. So in order for an aortic dissection to occur, you need two things to be present. You need tension on the wall of the aorta, and you need weakness of that very important medial layer. The tension in the aorta is very high in the proximal aorta, right near the aortic valve, and in fact, this is where most aortic dissections occur. The reason the tension is highest here is because blood is being pushed out of the heart, and that creates very high tension in that section of the aorta. In addition, this is worsened by hypertension, and as we will see, hypertension is a very important risk factor for aortic dissection. In addition to tension on the wall of the aorta, you need a weak medial layer of the aorta. Now, hypertension also causes weakness of the medial layer. As we saw before, this can lead to decreased blood flow to the vasa vasorum and weakening of the medial layer. In addition, in many collagen vascular disorders, which are genetic disorders like Marfan syndrome and Ehlers-Danlos, there is genetic and inherited weakness of the medial layer, so this predisposes to dissection. Another important term for you to be familiar with before we talk about specific risk factors for aortic disease is the term cystic medial necrosis. This is the development of cysts and necrosis in that very important medial layer of the aorta. This occurs to a mild degree with aging, and as we will see, age is a risk factor for many diseases of the aorta. In addition, this process is more rapid and more severe if you have a bicuspid aortic valve or the Marfan syndrome. In both of these conditions, there is what's known as an aortopathy, which means the aorta is not normal, and what you see histopathologically is the development of early and more aggressive cystic medial necrosis. And this is common in patients who have dissection. It's also common in patients who have ascending thoracic aneurysms, which we'll talk about in a few slides. So now that we've gone through all that, it's very easy to understand the risk factors for aortic dissection. The first one is something that damages the aorta. Hypertension is the most common and number one risk factor for aortic dissection. That's because it puts tension on the aorta and it can limit the blood supply to that very important medial layer. In addition, atherosclerosis can predispose to aortic dissection, and so can the presence of a thoracic aneurysm, which we'll talk about in the next few slides. Second group of risk factors are those involved with abnormal collagen. So patients who have the Marfan syndrome or Ehlers-Danlos syndrome have problems making normal collagen. For this reason, that medial layer of their aorta is weak and therefore it's vulnerable to dissection. And then finally, there are other risk factors. The bicuspid aortic valve predisposes to aortic dissection, as we just discussed. Patients with the Turner syndrome often have a bicuspid aortic valve and or a coarctation. For this reason, they often develop aortic dissection. And in fact, that's a common mode of death among people born with the Turner syndrome. And then finally, tertiary syphilis used to be a very common cause of aortic dissection. Tertiary syphilis is very rare in the modern era, but decades ago when it was common, it would lead to aortitis. The inflammation that occurred as part of the syphilitic infection would involve the vasa vasorum. That would lead to an aortitis. So patients who had tertiary syphilis often developed aortic dissection or a thoracic aneurysm decades ago when tertiary syphilis was more common. So now that we've talked about dissection, let's talk about aortic aneurysms, which we've been touching on in our discussion of risk factors for dissection. The two are closely related. An aneurysm is a dilation or a bulge of the aorta to a size more than 1.5 times normal. What it looks like is a patient will have a section of normal aorta followed by a bulging section. It will bulge out on all sides, and there's a risk of rupture which can lead to death. That's why these are so dangerous. Aortic aneurysms are true aneurysms. They involve all three layers, the media, the adventitia, and the intima, and they can be subdivided into those that occur in the thoracic region, the thoracic aortic aneurysms, and those that occur in the abdomen, the abdominal aortic aneurysms. And of the two, AAAs are far more common than thoracic aneurysms. So first let's talk about thoracic aneurysms. These are an important risk factor for dissection. Patients with thoracic aneurysms are at greater risk for developing a dissection. They usually occur in the proximal or ascending aorta. Remember what I told you before, this is where the tension is highest. And usually thoracic aortic aneurysms are seen in association with some other disorders. So they're seen in patients who have Marfan syndrome, Turner syndrome, bicuspid aortic valve, or syphilis. And I've bolded syphilis because, like I told you before, decades ago this was far and away the most common cause. New and emerging data says that family history of aneurysm is very important. There are likely genetic factors that predispose to development of these aneurysms. And then finally, you should know that these can be associated with atherosclerosis, although it's far less common for thoracic aneurysms to result from atherosclerosis than it is for abdominal aneurysms, which we'll talk about in a minute. When patients do have an atherosclerosis associated thoracic aneurysm, it's usually in the descending aorta, not the ascending aorta, and it often occurs in association with atherosclerosis risk factors like hypertension, smoking, and high cholesterol. Most thoracic aneurysms are asymptomatic. Many patients are identified by screening. For example, patients with the Marfan syndrome are often screened so that thoracic aneurysms are identified early before they can cause symptoms. You should be aware that they can lead to aortic regurgitation. Remember, most of these occur in the proximal aorta. This means that the aneurysm can stretch the aortic valve so that the leaflets cannot touch. This can lead to aortic regurgitation. And we often monitor these, and when they increase in size and get greater than about 5 centimeters, we perform surgery, because at that point the risk of rupture becomes high. Abdominal aortic aneurysms are much more common than thoracic aneurysms, and these aortic disorders are classically taught as a disease of atherosclerosis. The reason for this is because they almost always occur in conjunction with atherosclerosis, and in addition, the infrarenal aorta is the most commonly affected portion of the aorta by atherosclerosis, and that also happens to be the most common site of AAAs. If you look at this picture on the screen, the most common location of an abdominal aortic aneurysm is above the bifurcation of the aorta and just below the renal arteries. That is also the site that is most commonly affected by atherosclerosis. Now, you should be aware, however, that there is a lot of current research suggesting that factors other than atherosclerosis play an important role. There are data that genetic, environmental, hemodynamic, and immunologic factors all may play a role in the development of abdominal aortic aneurysms. But nevertheless, you should be aware that they almost always occur in association with atherosclerosis, and that's the reason that these are always taught as a disorder that results from atherosclerosis. So if you remember that abdominal aneurysms are commonly associated with atherosclerosis, it's very easy to remember the risk factors. Smoking is one of the strongest risk factors for development of a AAA. It has the strongest association with development of AAA in many clinical studies. Males are 10 times more likely to develop an abdominal aortic aneurysm than women, and age is also an important risk factor. These are very rare before 55 years of age, and they're as high as 5% in some studies in men greater than 65 years of age. In addition, hypertension and hyperlipidemia are also risk factors. So the classic patient to develop an abdominal aortic aneurysm is going to be a male smoker about 65 years of age with these other risk factors for vascular disease. Most abdominal aneurysms are asymptomatic, and we screen many patients, especially male smokers around 60 or 65 years of age, because these aneurysms can occur and be asymptomatic. Some are detectable on physical exam. The classic finding is a pulsatile mass from the xiphoid to the umbilicus, which is the path that the aorta runs in the abdomen. The natural history is for them to steadily enlarge and then rupture, which can be life-threatening, and for this reason we usually follow them with ultrasound or sometimes CT scan, and surgery is usually performed if they get over 5 centimeters, because that's the point where the risk of rupture becomes substantial. The last topic I'll mention in this module is rupture of the aorta. This is a tear through all 3 layers of the aorta. This usually occurs secondary to trauma, and you should know that the most common site is the isthmus. The isthmus is the portion of the aorta just after the takeoff of the left subclavian artery. This tends to be a relatively weak portion of the aorta. Your aorta has some elasticity in the proximal portion and the arch. It then becomes very rigid in the descending and abdominal aorta. That transition from stretchy and elastic aorta to rigid aorta occurs in the isthmus, and that's a vulnerable place where aortic rupture can occur, and once again this usually happens secondary to a major trauma. And that concludes our module on aortic dissection.